Welcome to this session today, which BASW England have put on to coincide with Mental Health Week. Looks like we're going to have a really interesting session this afternoon. We're just welcoming other people in. We've got quite a number of people signed up today, so it may take a little while just to get everybody in through the lobby. But hopefully you're here for the session, which is around what does a social worker bring, and where we're going to be considering the complexity of mental health assessments and mental health work generally with children and young people. I'm just going, in terms of kind of what to expect throughout the session, we're going to have a presentation from Annabel. We're then going to have, which will be approximately 20 minutes, we're then going to move over into a presentation from Sarah and Carole. I'll do introductions in a second. We've then got a recording and we will then open it out to the Q&A. Okay, so it's an hour and a half session, and as I said, please use the chat function. Okay, so that said, I would like to now welcome our first speaker, who is Annabel Smith. Annabel is a professional lead for social care in a child and adolescent mental health service. She's worked in CAMHS since 2005 and has recently established a network for CAMHS social workers. Annabel is currently undertaking a doctoral research into the experiences of social workers within CAMHS services. So hopefully all goes well, and we're really looking forward to this because I think it's going to be a really interesting session today. So Annabel, over to you.
Thanks, Denise. I'm assuming you can see the slides.
We can, yeah.
Great, thank you. And thank you to BASW for inviting us to really shine a spotlight on working with children and adolescents with mental health difficulties. It's perhaps a less well known about area of social work than some others. And we're doing quite a lot of work at the moment to raise awareness around this particular area of work. So I feel really grateful to have this slot, and it's lovely to see so many people here. I'm aware that I look like I'm somewhere very hot and sunny. I'm not. I'm in a very dark corner and I've got a light on. So you can rest assured I'm not somewhere in the lap of luxury. Okay, so thanks for the introduction. Yeah, my name is Annabel Smith. I work currently as a professional lead for social care in a child and adolescent mental health service in Hertfordshire. And for the purposes of this particular presentation, when I'm talking about CAMHS, I'm talking specifically about the services that work with children and young people with moderate to severe mental health difficulties. So I've been working in Hertfordshire CAMHS since 2005. Prior to that, or the start of my career, I did a psychology degree and then got a job working in the local authority. For a while, I was working in family support, where our casework was 50% preventative and 50% child protection. And whilst working there, I was lucky enough to be sponsored to train as a social worker. And for my final placement, I really wanted to find a placement in CAMHS. I wanted to do something where I could join together my dual interests around social work, but also around psychology and mental health. So I was fortunate enough to get a placement in our local CAMHS team, and I haven't left since. So I've been there as a student and then worked my way up from a clinical social worker to now being the lead social worker for our area. So I'm going to, for the purposes of this presentation, take us through a little bit around the history of social work in CAMHS, then thinking about sort of the current prevalence of what we're seeing with children and young people, and why a social work role is really important in this particular area of work. And I'm going to do a little bit of myth busting, and then I'm going to just show you a practice framework model that we've been working on in Hertfordshire. So without further ado, let's move on. So a quick history of CAMHS. In 1928, the Child Guidance Council was set up to encourage the provision of skilled treatment of children showing behaviour disturbances and early symptoms of disorder. This was the result of pressure from education and health officials who were concerned about the abilities and behavioural problems of children brought into the new statutory compulsory education system at the beginning of the 20th century. These developments were actually influenced by innovations in the USA, where the first child guidance clinic was established in Chicago in a deprived neighbourhood. can see there that the interplay between social deprivation and children's emotional problems had begun to be correlated, highlighting the need for a social work dimension to assessment and intervention. At that time, services comprised of an MTT, which included health, education and social work, staffed by a lead psychiatrist, assisted by an educational psychologist and trained social workers. So social workers were in there right from the beginning. The social worker's role would be to find out the social circumstances of the family, be part of diagnosing the child and be part of prescribing treatment. And social workers were expected to offer individual psychotherapy, family counselling, parental guidance, conduct risk assessments, and get involved with child abuse cases. So, as I said, we can see from here that social workers were a key component within the service from its conception. And I don't think that that's actually widely known or recognised. Just after the war, psychoanalytically trained childcare specialists arrived in the UK as refugees from Europe, and they were able to exert influence within child guidance clinics. However, psychoanalysis was really not understood very well by proponents of the medical model, and this caused the service to change in favour of evidence-based medicine and evidence-based education. And this in turn led in the 1990s to a public policy motivated formal takeover by the NHS, with the impact of that being an increase in the service employing practitioners who could offer evidence-based interventions, such as clinical psychologists, and alongside this, a slow decrease in specific social work role began. In addition to this, outside of CAMHS, social workers, well, there's evidence and research to show that social workers outside of CAMHS saw their CAMHS counterparts behaving like therapists. And this further isolated those CAMHS social workers from their fieldwork colleagues who were bombarded by high levels of demand. So the focus on evidence-based practice came at a time when government policies emphasised and accelerated the growing culture of managerialism and the search for more cost effectiveness, again combining to further erode the case for maintaining a strong social work presence in CAMHS. So currently, there are trusts that employ social workers in CAMHS services, and there are trusts that don't, and there are trusts that employ a lot and some that employ a couple. So it's really different across the country what you'll see and what you'll find in terms of CAMHS social workers. Some are employed via the local authority, some are employed directly by the NHS. So there's a lot of variability across the regions. So, what do we know about childhood mental health? We know that the problems are common and increasing. Almost 1 in 5 children aged 7 to 17 now has a probable mental disorder. That is a 50% increase from 1 in 9 in 2017. The number of younger children reporting mental health difficulties and seeking support has increased. Childline reported a 29% increase in children aged 5 to 11 seeking support for their mental health, and this echoes reports from the Care Quality Commission that younger children have started to present with poor mental health over the last few years. There's also been an increase in significant mental illness and the number of children and young people experiencing mental health crises. This includes increases in emergency department attendance and hospital admissions due to mental ill health, suicide attempts, self-harm and eating disorders. Rates of self-harm remain high for young people, with almost a quarter of 17-year-olds self-harming each year, and suicide remains one of the leading causes of death for young people in the UK. What do we know about this? We know that childhood is the key time to intervene. 50% of lifetime mental health problems are established by the age of 14 and 75% by the age of 25. So we're increasingly aware of the importance of good mental health in early childhood, and there are worrying signs at the moment that this is worsening rather than getting better. Another key fact that we know is that mental health problems are not evenly distributed across society, and they intersect with other forms of inequality and vulnerability. Children from low-income households, parental mental illness, LGBTQ+ children and young people, those with special educational needs or disabilities, looked after children, and those in the criminal justice system are all significantly more likely to experience poor mental health. A social work view of mental health problems could be summed up as below, with mental health being in the middle and as having individual attributes and behaviours that contribute, but also social and economic circumstances and environmental factors. Interestingly, a recent briefing by the Commission for Equality in Mental Health gives an important reminder of how social determinants affect people's chances of experiencing mental health problems and their ability to move towards recovery. So it makes sense that social intervention should be a focus of energy in the community. Public Health England 2015, their definition of mental health and well-being states, it's a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. For me, this definition reflects that mental health and well-being is not simply the absence of mental illness. It's influenced by an individual's experience and the circumstances they find themselves in, and the broader environment or society they live in. This can be summed up as a psychosocial understanding of mental health. So why have social workers and CAMHS? I mean, I think I've already given some clear kind of background as to the social determinants around mental health. It almost feels kind of obvious, like why do we even have to ask this question? But it does feel like we have to sort of demonstrate our use and our worth in mental health services. So social work principles of empowerment, service user focused practice combined with a social model of human growth and development are valuable perspectives to bring to interagency work in mental health. Social workers in child and adolescent mental health services aim to work in partnership with service users and colleagues in multidisciplinary teams and professionals in other services to identify needs, to facilitate emotional support and effective interventions for children and young people from infancy to 18 years of age and their families. As I've said, the guiding principle is one of empowerment in the promotion and maintenance of the young person's positive mental health. The ability to work in and with the whole context or situation is an important distinguishing characteristic of social work practice. And there's an argument that social workers have a unique capacity to hold on to the external reality, what's happening around the family, and the context of the whole family experience. That capacity to stay with the pain of each family situation, to see the patterns and sequences evolving, and to assess the impact of social policy and political changes on children and their families is important. The choice of intervention open to social workers in child mental health work, for me, is necessarily broad because of the wide variety of psychological and social factors influencing the children or young people being helped. We draw on different theoretical resources in line with what's considered to be most useful to a particular person at a particular time, rather than being constrained by one model or approach. Sociological theories concerning the construction of childhood are a useful addition to the medical literature in CAMHS. And social workers who use biopsychosocial approaches in social work recognise their service users' mental health and well-being are influenced not only by biological and psychological factors, but also by social and environmental factors such as poverty, discrimination, lack of access to healthcare. On top of that, social workers are trained in delivering difficult messages, working with people who don't want to engage, going out into hostile environments, doing things quickly under stress, and balancing people's rights in the legal picture. Social work as a profession has led the field in its emphasis on collaborative practice, the importance of consulting service users, and its commitment to anti-discriminatory practice and equal opportunities. Some common myths that have arisen in terms of CAMHS social work. We don't need social workers in CAMHS because we have social care. Well, I think what I've been demonstrating in the previous slides is actually there's a slightly different role in terms of the role that social workers are taking in CAMHS. We work very closely with our social work colleagues in social care, but we're contributing towards the picture of what gives somebody mental illness or what causes mental distress in young people and families. is not just about something within themselves, and it's really important to challenge that medical view and medical understanding in order to give children and young people the best outcomes. A social worker's role in CAMHS is about safeguarding. It is about safeguarding, but it's more than safeguarding. Safeguarding is everybody's business, and in an MDT, everybody should have focus on safeguarding practices. We can often bring knowledge of local authority, we can bring knowledge of procedures, we can bring knowledge around child protection and assessments and the legislation. But and we can be there to guide our fellow clinicians. It's not our only role in CAMHS. There's a view that social workers must have lots of previous experience to come into CAMHS. And I think certainly that might have been the case a few years ago, and it's something as professional leads we're really trying to challenge. There used to be a view that you needed to have further therapeutic training in order to work in CAMHS. We believe strongly that the social worker skills that social workers bring are enough. They are more than enough to work in a CAMHS service. They don't need to have more and above that in order to provide a helpful service. And that's something that we're really challenging nationally. Various trusts now are in different kind of places in terms of their programs. But for example, in my trust, we take people from students, we do ASYEs, and we have people that we can, progress through their entire career. So it's not necessary to have lots of previous experience or to be trained in something else. CAMHS is impenetrable for social workers. There is a view that it can be really difficult to get into CAMHS, and you're sort of lucky if you get a place or a position in a CAMHS service. And again, that's something that we really want to challenge as professional leads through our social work leads network. It shouldn't feel impenetrable. There should be opportunities. We strongly believe that there is a role for social work in CAMHS, and an increasing role actually, in line with the increasing acuity and complexity that we're seeing of young people coming into our services. We're trying to break down barriers and make this easier for people to transition into NHS. And this is part of that. It's letting people know we're here. There are roles that you can access. All children and young people with mental health difficulties need therapy. This is a view I think that social workers in CAMHS are often challenging. Not everybody needs therapy, and actually therapy doesn't work for everybody. So therapy definitely has its place, medication definitely has its place, but so do other interventions and other ways of supporting along sort of social prescribing, thinking about community and relationships and all of those sorts of things that social workers can help with actually also contribute to people feeling better and doing better. Social workers in CAMHS aren't real social workers. There's too much talking and not enough doing. This I can really kind of relate to this when I first went over to CAMHS. That I think there was a view that there was a lot of what at the time was called navel gazing, people sitting around talking a lot and not doing very much. I suppose just really want to assure people that is not the case. There is a huge amount of work, very complex work, and definitely doing real social work. Just a little bit around the current picture of social work in CAMHS at the moment. Current figures suggest there's a growth in the number of social workers in CAMHS, and as this being a 51% growth, which sounds huge. In the latest CAMHS workforce mapping in community settings, social work made up 4% of the workforce. That is compared to 26% of nurses and 14% psychologists. So social workers are therefore still a much smaller professional group than others working in the same sector. However, with the growth in the number of social workers being employed, there's a pressing need for people to understand more about that role and the experience of those social workers to ensure that we retain social workers and that we can continue to recruit in line with the current presentation of our young people, that being young people arriving into our service with higher levels of complexity and acuity. For me, it feels like there's a really big space for social work to grow and contribute. So through my doctorate research, which Denise mentioned is in the experiences of social workers, and through my own experience and the experiences that have been shared within our trust and our social work forum. We've been doing quite a lot of work to try and bring a bit of clarity to exactly what the social work is. What is the uniqueness of social work in CAMHS? And I just thought I'd share really quickly with you a practice framework that we've been working on and developing. So here we have the clinical social worker, our values. Oh, it's all come. Our role, so who we are, what we do, how we do it, and what we know. I'll just give you all a little second to have a look at that. This is kind of like the outside of our model. So we've tried to do it in a way that it breaks down and gives people more information as you kind of look through it. So I'm going to just give you a bit more information on each of those sections. So our values and ethics, who are we? As child and adolescent mental health social workers, we bring with us an understanding that there are lots of things that contribute to mental health and well-being that don't come from within us, but come from the society in which we live. For example, where we live, what school we go to, our friendships and relationships, our financial situations, and the cultures of our families and communities. We're committed to empowering you to achieve your goals in ways that feel safe, comfortable, and I can't read the last word because I've got a button on it. Our roles, what we do, we're flexible. As social workers, we work flexibly, thinking with you about what works best for you and adapting our ways of working so as to meet your particular needs. We're adaptable in the way we'll work with you. We have a whole array of experience and skills we use as and when the need arises. We're navigators. We help the people we work with to find their way through all the different services that might be available to them. And we're translators. We're very good at helping to make sense of different services and linking everyone and everything up so you get your voice heard as you want it to be heard. How do we do it? We're trained in and we offer mental health assessments and interventions, trauma-informed approaches to care, mental health risk assessments, mental health risk management, network liaison, group work, individual work, family support, psychodynamic practice, behavioural practice, empowering interventions, screening for other clinical presentations such as ADHD or autism, and offer specific therapeutic interventions as well, for example, CBT. We're trained in and understand a variety of legislation that's important when working in mental health. For example, child and family law, mental health legislation, human rights and equality legislation. We have a series of professional standards that we have to adhere to, including promoting the rights, strengths and well-being of people, families and communities, and acting safely, respectfully and with professional integrity. We're trained in anti-discriminatory and anti-oppressive practice. So that's a bit of a little kind of whistle-stop tour around what it is to be a social worker in CAMHS. I'm now going to hand over to Sarah to take you into the world of AMP.
I'm just going to do introductions. That was fantastic. Thanks, Annabel. So for anybody who joined a little bit late, I'm Denise Monks. I'm chairing today and I'm a professional officer with BASWA. Just in case, I am aware that sometimes for Teams, any messages that were posted before you joined may not pull through. So just a reminder, please do put your questions in the chat, and where possible, keep your mics on mute if you're not asking a specific question. We have got Q&A at the end. So in terms of Annabel, I just have to say that presentation, absolutely fantastic. For me, personally, understanding that role, we all know that when integrated services and MDTs, it can be really difficult, can't it, to kind of articulate what a social worker does, and I think you've really captured it there. So I think there's a lot that other areas could learn from that, and other social work roles in terms of how we explain to others what it is that we bring and our values. So thank you for that. I think also I'd just like to reflect that actually in terms of understanding the intersectionality and the social determinants around mental health. I think you've really clearly articulated, and I thank you for that. And the bit that for me really resonates was understanding actually, where did CAMHS come from? That's the first time I know you've reflected it there, that actually not many people know it. I'm one of those people. Understanding the history and the background to CAMHS and kind of how the role came about, and how social workers became involved in that from the very outset was really interesting. So I'm going to hand over now. I'm going to introduce Sarah Redmond and Carole Baxter. Sarah's been a practicing social worker for 20 years and is an approved mental health professional for 11 years. Her background is in children's services, but she's currently in her 13th year of working on an emergency duty service in a generic social work role. Sarah's involved in research through the Clinical Research Network, and her area of interest is in the assessment of children and young people under the Mental Health Act. Sarah also teaches at local universities, including Staffordshire University and the University of Birmingham, with a focus on the AMP role. Carole, who's going to be co-presenting with Sarah, is a clinical social worker, senior clinical social worker and AMP. And Carole's background is 14 years in mental health social work, including 5 years in a CAMHS inpatient unit, and she currently works in a community CAMHS clinic. So I'm now going to hand over to Sarah. Thank you.
Thank you. Hello, everybody. Thank you, Denise, for that introduction. Even as you were reading through it, I thought, goodness, that's a busy old role, that is. Thank you to Annabel as well, who's really kind of set the scene in terms of what I wanted to talk about today. So, as Denise said, I'm Sarah Redmond and I'm a social worker, originally from a children's background. That's where I started out. But 11 years ago, I did my approved mental health professional training, and I've been working as an AMP ever since. And I currently work as a shift lead on the emergency duty service. Alongside this role, I've also been working as a research associate 1 day a week. And as Denise said, my research is really focused around the assessment of children and young people under the Mental Health Act. And I've recently completed a service evaluation across the trust and the local authority that I work for, looking at the numbers of children and young people that we're assessing under the Mental Health Act, and also taking on board the views of other approved mental health professionals who are operating in this area, because the national picture is that AMPs are, generally speaking, working across a spectrum of Mental Health Act assessment. So they're often on duty rotas and they're undertaking Mental Health Act assessments on adults and children, older people, you know, in all kinds of circumstances. And actually, only 3% of AMPs currently come from a CAMHS background. So that was kind of my starting position, is how are we doing these assessments? They're very specialist assessments, and I'll explain why I think that as we sort of move through. So my presentation really is focusing on, if you like, the acute end of mental distress for children and young people, because that's often at the point that they present as for a Mental Health Act assessment. And there's a reason that I wanted to look into this. And really, the first reason is because we know that the number of children and young people being assessed under the Mental Health Act is growing year on year. In fact, data taken from my service evaluation shows that there's been an 84% increase in the number of children being referred for Mental Health Act assessments in the last 4 years. And second to that, the number of children and young people that are coming into hospital as a result of being assessed under the Mental Health Act, so being detained under the Mental Health Act, is also rising. And that isn't necessarily due to the fact that we're assessing more children, because I actually worked it proportionally across how many assessments we were doing and what proportion were coming into hospital. And that, as I say, is also rising. There's been a 10% increase in the last 4 years in the number of children and young people coming into hospital. And in addition to that, the age of children being assessed under the Mental Health Act is also decreasing. So for those of you that are familiar with the Mental Health Act, you know that there is no age restriction. So you can be assessed at any age or be referred for assessment at any age. And we've had children as young as 4 being referred for assessment under the Mental Health Act. I have to say, we haven't always gone ahead with those assessments. I'm just sort of setting the context. And finally, and perhaps most importantly, why this is such an area of interest is that we've found that there's an increasingly complex picture emerging of the experience of children and young people, particularly those from marginalised groups that Annabel talked about earlier. And within those groups, I also include looked after children who are often presenting with a history of trauma and seem to fall between the health and social care systems and struggle to access the right type of support at the right time. And for me, or in my experience, this really creates, if you like, a breeding ground where we often see behaviours which are manifested in emotional distress and emotional well-being. And these children and young people are often described, sadly, as disruptive or challenging or hostile. And we see that they're often living across a number of sort of disrupted placement settings, and sadly experience self-harming and self-injurious type behaviours and suicidal ideation. And these are the children and young people that social workers working in children's services are trying to support, and colleagues working in CAMHS provision are trying to provide appropriate levels of support for. And increasingly, where there are gaps in services, we find that these children are presenting in crisis. So that's why I approached this sort of area of research. So before I get started, I just want to look at some of the statistics. And obviously you can read these for yourselves, but we can see that, as Annabel said, 1 in 5 children and young people have a mental health difficulty. So that's 20% of 8 to 16-year-olds, and a slightly higher rate for the older children. And data varies about how these children are coming into hospital and under what circumstances. NHS Digital have just started formalising how they collect data, but we believe there's about 3,500 children under 18 coming onto the wards every year, and about a third of those are formally detained. And you can see the statistics from the Mental Health Bulletin that the age split, and some of them are quite shocking really. So 2% of those children that are coming onto the wards are under 5, but obviously the higher rates of children you'll see from 11 plus. And the number of children with learning disabilities coming onto the wards has doubled since 2015 and is increasing. And in terms of a gender divide, girls are far more likely to be detained under the Mental Health Act than boys. Generally speaking, it's a 70-30 split. So about 70% of girls, 30% of boys we see coming onto the wards, although that is changing and the boys are increasing in number. And I would suggest that that's often the way in which mental health difficulties manifest themselves in boys and girls. But there's lots of research for that, and unfortunately I don't have the time to delve into it today, but there's lots of information that talk about how mental health manifests across boys and girls. And sadly, in 2020, 600 children were detained on adult wards because of struggling with resources and things, but I'll come on to that a little bit later. So let me talk about the role of the AMP, because as I say, only 3% of AMPs that are currently practising come from a children's services background. And there are lots and lots of parts of assessing children under the Mental Health Act that are different to how we assess adults under the Mental Health Act. And I just wanted to draw some of those out today. So what's the role of the AMP specifically in the assessment of children and Mental Health Act? Well, first of all, you're the facilitator. So you receive the request for a Mental Health Act assessment, and you take on the responsibility of organising the doctors, doing all the practical elements, where the assessment's going to take place, when it's going to take place, any additional support that needs to be identified for that child or young person, and effectively what that assessment is going to look like in practice and who's going to be there. Now, for those of you that know the AMP role and the assessment process under the Mental Health Act, there should be 2 doctors and 1 approved mental health professional. And the code of practice clearly says that where possible, one of the doctors should come from a CAMHS specialist background. And where that's not possible, then either the AMP or a social worker with experience of children and families should contribute to the assessment. And in the research that I completed, only 70% of the respondents, in terms of the research that I did, had said that assessments had been delayed because they hadn't been able to get the right people, the right doctors, to the assessment on time. And only 30% of AMPs had said that they have reliable access to doctors from a CAMHS background. So the picture that I'm building here, I guess, is that we've got only 3% of AMPs from a CAMHS background doing the assessments. So across a general picture of all of the AMPs, only 30% of those have had reliable access to CAMHS doctors. So you can see the impact potentially that this could have on the outcome of those assessments. So that's facilitating the assessment. The next thing we take on board, well, we're actually doing all of these roles all at once, but I've broken them down, is we become almost a bit of an investigator in the AMP role. So we start looking at why is this particular child or young person presented today? What's happened that's led to this referral for a Mental Health Act assessment? What events have precipitated this presentation? Are they open to other services? CAMHS? Are they a looked after child? What support networks do they have? All the things that we do as part of our social work assessments generally, and feed specifically into this AMP role as well. And the survey that I did found that only 26% of respondents said that they had reliable access to health information. So that's whether the children had been known to CAMHS before and in what circumstances. And sadly, even less, 21% of AMPs responded that they'd had reliable access to social care information. Now, when we think of the children that are being referred for Mental Health Act assessment, many of them come from a background of trauma or may have experienced adverse life experiences. We know that the likelihood is that they may have also come through social care services in some shape or form, and we're not able to always access that decision. So we don't always have the right people involved, we don't always have the right information available to us, and that, for me, I think really has quite an impact on the outcome of the assessments. Next part of our role is setting the scene, and basically what I'm referring to about that is looking at the expectations of the people that are involved. So you have other professionals that are involved. So, for example, maybe doctors, nurses, paramedics, police officers, social workers, residential workers, all of the professionals that could potentially contribute to these assessments or have referred for assessments, and what is their expectation. So often you can have a child that's perhaps a looked after child that's in a residential unit, and the expectation of the social worker and the residential workers may be that this child meets the threshold to come into hospital. So there's lots of, if you like, focus on hospital admission and detention being the outcome, and the AMP and the doctors really are responsible for setting that scene, that there are other options that may need to be considered. On the other side of it is, we do have children and young people that are coming to us, you know, with support from their families, perhaps children who maybe are experiencing an eating disorder, where their families are incredibly engaged in trying to support them and offer them a degree of care at home, and really don't want them to come into hospital. It's kind of their last resort. So, you know, the AMP takes on the responsibilities of both, really setting the scenes for the professionals, but equally setting the scenes for the families and the parents and the carers. And then, as Annabel alluded to in her presentation, we also become responsible for considering all of the options that could potentially be available as a result of these Mental Health Act assessments. Not only do we have the very strict criteria of the Mental Health Act, where the possible outcomes could be detention under Section 2 for 28 days for assessment, or detention under Section 3 for a period of assessment and treatment. There's also the option of informal admission, so the child is agreeable to coming into hospital, and there's also the possible outcome of them remaining in the community, which means we do the assessment, but we say no, community services is the least restrictive option. And even that isn't straightforward, because if you're looking at a child or a young person and you're going to consider offering them informal admission, then there's got to be some understanding of their capacity or their competence to make that decision. So even that becomes quite involved, and there's lots of elements to that the AMPs need to consider. And the law, the case law is very clear that if a child or if a child is 16 or under 16, they're considered a child, so we should be considering their competence. And if their young person is 16 or 17, then we can consider their capacity. So there's lots of nuances to the way in which informal admission is considered. And the bigger picture around informal admission is if the child does not have capacity to make that decision or competence to make the decision, do we offer the opportunity to parents to consider agreeing informal admission on their behalf? And there's a whole world of things that need to be considered there. And in addition to that, while we're considering all of our options about what may happen to this child or young person, we need to have a good understanding of the Children Act and whether the criteria would be met for a welfare order under Section 25, or whether this child or young person, if they're looked after, may be subject to inherent jurisdiction decisions through the family courts to see whether they can be deprived of their liberty. There's lots and lots of legal considerations and options that we bring to these Mental Health Act assessments. And then the crux of the assessment, the big part of the assessment, which is the analysis of the risk. And really, for children and young people, this is where it all comes together, is what does that risk look like? Because no mental health professional or doctor would want to choose the most restrictive option of coming into hospital or detained in hospital unless they really had to. And what influences that decision most heavily is that analysis of the risk. And I'm going to talk about that in 2 minutes. But I just want to finish off by saying, after the assessment's been done, then we take on the role of what I jokingly refer to as the logistical juggler. But that is what the AMP role then becomes, because then a bed needs to be identified. And for children and young people, different to the adult, where the beds are coordinated locally, for children or young people, it's coordinated nationally by NHS England. They have to agree a bed, which we don't have in adult services, because once the detention, the 2 medical recommendations have been completed and the application, then a bed is found. NHS England will often request further assessments or a different view from a doctor. It gets very, very complicated. Then we have to organise the practical logistics of transportation safely, making sure that children and young people have access to the right information. And our survey found, at the risk of sounding like family fortunes, our survey found that that AMPs in the majority do not have access to age-appropriate information to provide children and young people in relation to their detention, and equally to their nearest relatives. So there's lots and lots of gaps there. So this is what the assessments look like, if you like. And what I really want to focus on in the final section of my presentation is, how do we assess that risk? So what does that risk look like? And when we're considering the risk, like we do in any social work assessments, what we first of all do is recognise what might be impacting on that risk. So we look at what professional anxiety is being brought to the assessments. Often there's a lot of heightened anxiety, because as I say in the third point, there's a heightened sense of responsibility because of the age of the child or young person. It often brings professionals to a point where they want to protect and safeguard and even nurture and maintain a well-being that actually sits outside of what can be achieved within a hospital setting. So we have to consider what professional anxiety is contributing to the assessment, the impact that the family and friends or carers' perspectives are having on our assessment. We have to accept that there's often a huge range of opinion with regards to where that child and young person is in terms of their emotional well-being and their mental health. Is it just a phase? Are they in a difficult patch? You hear all of these phrases sort of bandied around in terms of, tomorrow they'll wake up, they'll feel differently, but there's a lot to talk about minimising the impact of their mental distress as well. And we've got to make sure that as AMPs that we guard against that. But we also have to consider, what are the motivating factors for people requesting these Mental Health Act assessments? And that could be a session on its own, but it's just something that we're mindful of. But what it boils down to is, what is the risk? How do we assess that risk, that perceived risk, through the professional anxiety, the heightened sense of responsibility? What's the perceived risk against what is the evidence of risk? And this is the framework that we use, and we look very specifically at 3 sectors, very similar to the framework that Annabel showed us. So we look at 3 different areas. We look at the family factors that might be impacting on this child or young person. We look at what the individual factors are that are affecting this child and young person, and we look at the social factors. And we break it down into 3 specific areas. So first of all, we look at what could be affecting their mental health generally. So within each of those 3 sections, what's affecting them generally? Their mental health. It may not necessarily need admission. These are factors that could benefit from perhaps early intervention services. And then we start to bring up our risk management framework, if you like, by considering other variables such as self-harm or self-injurious behaviours, and also suicidal ideation. And the next 3 slides are what the research tells us about how we can evaluate that risk. So looking at family factors first, you can see I've broken it down into 3 columns. So the type of things that affect children's mental health generally, that's in the first column. But then you build in where there may be an element of self-harm, and you can see that there's very specific factors that we would then start considering. So if a child is self-harming or has self-injurious behaviours and there's a history of abuse, or there's alcohol, substance misuse in the family, or there's high levels of conflict, then if there's one or more of those factors present, then we can see that we start moving up the risk scale. And with suicide, you can see there's, or suicidal ideation, we can see that there's a slightly different pattern of family factors. And if we know that there's a history of suicide in the family, particularly on the maternal side, mental illness in siblings, history of admission to hospital, we can see if any of those factors are present, that starts to increase the risk in terms of how we assess where this child or young person is. And then on the next slide, exactly the same framework, individual factors, we look at things that could be affecting their mental health generally. And then if they have self-harming, self-injurious behaviours, if any of those factors are present, that starts to escalate the risk. And again, if there's suicidal ideation and there's any of those other factors in the background, that then starts to increase the risk. And then on the final of the 3 slides, same framework, is what influences influencing them in their social factors. And you can see again slightly different factors across the mental health, the self-harm and the suicide. And that's how we start to develop these risk assessments, and how we measure whether children and young people would benefit or require hospital admission in terms of their own safety or the safety of others, which is the criteria that the legal definition that's used in the Mental Health Act. So my final slide really is just to conclude and say, how do we conduct the assessment? Well, the advice that I give to all approved mental health professionals and students, candidates that are in their training programme is always know your role. And Chapter 19 of the Mental Health Act Code of Practice is very specifically related to the assessment of children and young people. And take the time. AMPs have a wealth of social work skills that we can draw upon, or they can draw upon, to conduct these assessments. They can feel very overwhelming at times, but actually the skills are firmly embedded in our social work practice already. It's just harnessing those. I always say to AMPs, hold the perspective. The legal frameworks are very, very complicated, but it often comes down to something very specific. That in like any social work practice with children and young people, often the situations appear very complex, but what we actually boil down to more often than not is just 1 or 2 options that we've got available to us, where you can use the right people, and that is completely dependent on the circumstances that you're coming to. But at the very least, we should try and get somebody, whether it's the AMP, whether it's a social worker, or whether it's a doctor, from a CAMHS background, because so many of the factors that influence children and young people, as you've seen from the previous 3 slides, are very social perspectives. Okay. and then look at doing it at the right time, and also in terms of understanding risk. Oh, somebody's taken control of my presentation. It's going off on its own. I'm going to take back control. I'm not quite sure how that's happened. Sorry. So in terms of trying to assess risk, always look for cooperative consultation. So when there's lots of people contributing information, try and look where those key themes are. What I'd like to do now is share with you an audio of a young person that I interviewed who had experience of being assessed under the Mental Health Act. Now, to maintain their anonymity, the interview was transcribed and has been voiced over. And it's a very clear reflection of their assessment, their reflection of being assessed under the Mental Health Act. A couple of things that I'd like to say. Firstly, there's about an 8-second delay at the start of the audible. Sorry about that, it will come. The other thing is some of my questions may sound slightly abrupt. And I just wanted to reassure everybody that this actual interview took place over 50 minutes and has been condensed into 10 minutes. So I apologise if I sound abrupt, but if I can assure you that I did offer lots of support during the interview as well, but I did need to condense it. So I'm going to play that. I think this really offers a good context into the experience of being assessed under the Mental Health Act.
Hi, Sam. Thank you so much for agreeing to do this today. I'm going to ask you just a number of questions, and if you're happy to share, some of your thoughts. Can you recall or remember the first time that you were assessed under the Mental Health Act and what that was like?
Yeah, August 2021, I think. It was absolutely horrendous. There was no explanation of what was going on. I was taken to a random place. Police are more helpful than any mental health professional. It was not nice not knowing what day or what year we were in, anything, and all of a sudden I'm being assessed by about 5 different people, being searched by police and mental health professionals, and being restrained for ticking because I have serious tics.
And on this occasion, can you remember, were you taken from your home or from another place? Were you out and about in the community when the police came to you?
Out in the community.
And did they explain what they were doing or where you were going?
They explained I was detained under 136 and took me to hospital A&E. When we got there, they didn't explain anything. I was there for about 5 hours, and then they told me that a bed had come up in the 136 suite, but they didn't tell me anything else. Police were as confused, really, and they took me there, and then they retreated.
Okay, goodness.
Even the police had realised that it wasn't right, and they were waiting round, and then they sort of said, "We're going."
Okay, so you went from A&E over to the 136 suite as far as you can recall.
I was put into the adult 136, so that was a different level of fear, because you got someone else in the other room. There was screaming and shouting, and they were probably about 20 years older than me at the time. There was one staff member who really couldn't care less.
And can I ask how old you were at the time?
17.
17. And did you have any idea of what was going to happen or what was going on or who might be involved?
No, nothing at all.
So you're in the 136 suite and then a number of people come in. How did they introduce themselves?
They didn't. All they said was that we're here to do a mental health act assessment. And I was a bit like, I was confused because I was like, well, why? Because I said I didn't know where anything was. I didn't even know my name as well at that time.
And did you know what a mental health act assessment was?
No.
And did they explain to you what could happen as a result of a mental health act assessment?
No.
And were you clear about what the purpose of the assessment was or what might happen?
No.
Can you remember how you felt?
I mean, like about 10 hours before, I was standing on the railway bridge planning to jump in front of a train. Then all of a sudden, I'm being restrained by police and dragged into the back of a police van, taken to what? And then to a 136 suite, where I didn't even know the country I was in. It made me feel a hell of a lot more suicidal.
And what happened after that assessment?
I was discharged, even though I told them that I was still planning on killing myself. I was adamant on killing myself and they discharged me back. I can't remember where it was because I know I wasn't living at my mum's house at the time because I had had a massive argument with her and I ran away. She had kicked me out as well. And then they sort of discharged me, told my mum what had happened and discharged me to the streets.
And how did that feel?
It just shows that they don't care. That's it. That's all it. I found that no one actually really cares.
So all of that happened over quite a long period of time by the sounds of it.
10 hours.
That's a long time. And then you find yourself at the door being discharged or remaining in the community, as we refer to it in mental health services.
Yeah.
And were you feeling quite overwhelmed at the time?
Yeah.
And perhaps confused about what had gone on and happened?
Yeah.
And what did you do? Did you just leave?
Yeah.
Did you get any support?
No.
Even after you'd left, did you get any follow-up support in the community?
No. I mean, I left about a week late. Then, less than a week later, I got physically assaulted in the middle of town, ended up in A&E again, and got sectioned. Definitely that time. I think the doctor did section 5-4, and then section 2, and then a section 3 eventually. I went to an adolescent unit. Yeah, it's still absolutely hell. And nothing was going well in that place at all. They didn't even know how to speak to a patient.
That sounds like a huge amount was going on in a very short period of time. So just so I understand it, after that first assessment, you went to the 136 suite, you were told you were not going to be sectioned and that you were going to stay in the community. And then there was no follow-up support available after you went back into the community. And a week later, you found yourself back in A&E waiting for another mental health act assessment. But this time the outcome is different. Can you recall that assessment?
Yeah, a bit.
And was it the same people or different people that were involved?
I think it was different people, but I can't really remember the assessment so well. All I remember, I wasn't informed of anything. I was told, you're going into hospital and probably never coming out, which I kicked off at because you do not say that to anyone. Even when I'm in that mindset, you don't say that to anyone. Then you are never getting out of hospital. And they all said, all we're saying is the truth. When you present like this, you're never going to escape hospital. And then the assessment had finished and I just sort of tried running off.
It must have been, again, a tremendously frightening time for you. Did they give you any indication of what they meant by you're coming into hospital? Did you understand what had happened?
Basically, I could go anywhere in the country. They didn't say exactly the area, and they didn't say it would be out of the area. They didn't know either. They didn't know anything either. But they didn't even say that. They didn't even admit the fact that they don't know where it could be. They left me and then came back, and then he said, it's good, you are sectioned.
And did you know what being sectioned meant? What was your understanding?
All I knew, it was when you were basically forced to go into hospital, which is what it is, they think. They really are different sections of like section 2, 3 and 136 and all that was.
And did you know why they were taking you into hospital?
Not really.
And did they explain to you how they'd come to reach that decision?
No.
So once you were in hospital, what happened then?
All I got told was I was acting strangely by having weird movements, which is my tics. I was apparently being quite aggressive to them, which would be my tics, and obviously fact I wasn't being told anything. That's no grounds to section someone.
Can I ask, how long were you in hospital after that assessment and that sequence of events?
9 months.
9 months. And when you think back to that time, what kind of impact do you think that the assessment and the admission in those early days, how did it shape the rest of your experience in the hospital?
Well, the hell had only just begun. I mean, there was abuse like those, the whole lot of that for every unit I've been into.
Oh goodness, I'm sorry to hear all of that, and it sounds like a really difficult time. Can I ask, have there been any particular parts to those assessments that you look back on that you think could have been done so much better or would have really helped you at the time, even the smallest of things?
Yeah, I mean, real communication, not through doors, just introducing yourself. There's so many times they just walk in and just start the assessment without even saying, I'm a psychiatrist or whatever. Like, they didn't even explain what was going on. They didn't say anything, and they didn't even ask how I was. They just assumed everything. They'd make them decisions reading the paperwork before they even see you. There's been times where they've even refused to give me a mental health assessment because the paperwork said I was fine.
So is it fair for me to say that sometimes you felt that the decision had been made before they'd even met with you?
Yeah.
And how does that leave you feeling when you get that sense that a decision's been made before they've even talked to you?
All right. Just, I don't know, it just makes it worse because it's like they actually get paid to listen to you, but you can't even be bothered. How would that make anyone feel? They definitely treat me differently to everyone else because of how my behaviour was described as aggressive. I mean, you could randomly walk into that unit and you could see they treated me differently because everyone else there was like a princess and they treated me as if I broke the law and was a prisoner that deserved to be locked up forever.
In that 9 months that you were in hospital the first time, did it feel like you were going to be in there forever?
It was the fact I went through so many assaults in that place. It felt like neglect, like that was going to be my life forever.
What can I share with other social workers to help them understand what that's like to be a child or a young person in mental health services?
Actually listen to people and don't just make assumptions. Don't just act like because we're sectioned or gone into hospital that we don't have capacity. Yes, some people don't have capacity, but then there's loads of us that do have capacity, but do just have mental health issues. Does not mean we lack for brain cells. People assume that we don't have intelligence, but we do.
Thank you, Sam.
Thank you.
Thank you, everybody, for listening to all of that. And if I can just reassure you, I know it sounded like an interrogation from me, but I can assure you that the whole meeting went on for, like I say, in excess of 50 minutes. So I condensed it down, and I had to be able to provide the context to my questions, which is why it sounded like an interrogation. But I can assure you there was an advocate in the meeting as well. And afterwards we had a big debrief and we spent lots of time talking through those issues. The young person asked me very specifically to ask direct questions. They didn't feel in a place where they wanted to openly reflect on their experiences. They expressed lacking confidence and said, would you ask me direct questions? So I hope you'll forgive the interrogation style of the interview, but it wasn't like that in its entirety. So thank you. What I'd like to do now is I'd like to hand to my colleague Carole, who has also completed some assessment, some research around the experience of children and young people, and can offer us a much broader view, I think, in terms of I just want to make sure I've got the right clip. Yeah, a much broader view in terms of a range of experiences. So Carole, I'm going to go on mute and I shall hand over to you. And if you just give me the nod when you want me to move the slides forward.
Thank you, Sarah. I'm quite conscious of the time because there's a lot of questions in the chat, and I think it would be beneficial for people to have time to discuss their questions. So I just wanted to summarize really. I wonder if it would be better for people to be able to look at these. I'll just tell you about it.
Carole, just
yeah.
to say, I think it'd be fine to maybe, you know, if you want to have about 5 minutes on this, I think
Okay.
it should be okay.
Okay. So I was just going to explain that I used to work in adults and became an AMP because, as Sarah has mentioned, not many people from CAMHS seem to train to become AMPs. And then I moved across to CAMHS. So for a long time, I was the only AMP in the village. And so I made myself a bit of an expert about CAMHS AMP specifically because I was the only person in that role. So I do teach at the university as well on the AMP course. And so I kind of informally interviewed about 15 people that I had assessed under the Mental Health Act, children and young people and their carers, to get their views. Luckily, we are seeing more AMPs coming through, not just from CAMHS, but also from children's services. And I'd really encourage people to look into that training. But what I find really interesting about your audio, Sarah, so obviously we work in completely different parts of the country, but actually this young person has said some almost word for word, and in my slides, these are the voices of the children that have been assessed. The same themes are emerging, and that's from quite a small sample size. So I think there's a lot for us to take on board as professionals, not just in the AMP role, but even in our generic work with children and young people. Just to draw your attention to a couple of things, which I've just heard in the audio as well, and it's on the bottom of this slide, where a young person said to me, it's so important that someone makes a connection with me first, because often people walk into the room and would say, so tell me about your suicidal thoughts, and it's a complete stranger. And I found that, I remember it very distinctly, and I found it very powerful when he was saying, even if it's like a comment about what you're wearing, what music were you listening to, or some kind of small talk or engaging before you go in with the really heavy questions, because they don't have a clue who you are. The themes as well about, obviously, people are waiting around for a very, very long time. They might be assessed by multiple people, especially if you're brought in on a 136. Can I move that? Oh, I've just moved that, I think. Have I moved that across?
Sarah, you'll need to move it along for Carole, please.
Yeah, I've moved it along. It's next slide.
Okay, then. Thank you. I think the other big theme, which is also what the person in the audio had said, was about the hospital itself. So I would really encourage people, whether you work, whatever field you work in, if you're going to come across young children, young people who might have mental health problems, to actually visit the local CAMHS unit in your area. Because when people do their pre-AMP training, they often do ward observations, and 99% of those are done on adult wards, or people may have had experience of adult, just setting foot in an adult psychiatric ward. But I think CAMHS units are different. There is statutory education on site. Not everybody knows about that. There's a different kind of approach. It's very family focused. So I think just arranging a shadowing visit at your local unit is something that's really beneficial, especially if you're advising people. Because if they've got questions about where they're going, as you can see from the comments here, people assumed that it was a hospital, like a hospital they were in, like a general hospital, not a psychiatric unit.
Okay. Today, yeah, okay. All right, no worries. Bye.
If we can just move on.
He's not moving his one. No,
Somebody's not on mute. Oops. And then the next slide is about what the parents have said as well, the parent and carers. And a lot of that was about the timing of the assessment. I did notice in the question somebody said about a pre-assessment interview, a pre-interview interview, which is something that I always do, a standard practice, where I would see the young person first. Who do they want to be present? Because some people want their family present, some people don't, and that's a whole other long discussion about the pros and cons of that. but I think it's about making it accessible so that parents can attend, because often they're done at short notice. But if they've got other siblings at home and we're saying, can you just leave your siblings and come and attend this assessment that's happening now? So it's about really planning as much as possible and enabling the family involvement as much as possible where that is indicated. Another theme from family was about, again, long delays. And the other point I wanted to draw attention to is this one, which says the decision is reached quite swiftly and then everybody leaves with little thought to how the parent or child are going to react to the outcome. For many people, this might be the first time that an assessment has been carried out and they may need some support. Now, this parent specifically, this came about where we assessed somebody on the ward, and after that, the assessing team left. And actually, later that evening, this child carried out a very, very serious incident of self-harm. But the point is that there was all the build-up before the assessment and during the assessment, but then afterwards, they're left sitting in the room together and no one's really, they didn't feel that there was that care and support after, and a consideration about the impact of the decision, telling somebody who's been detained and just leaving them to sit with that decision, really. And I think that's it. So we'd welcome your questions.
That's great. Thanks very much, Carole and Sarah. That was really, really informative, and I think probably speaking on behalf of everybody, really powerful audio, just being able to hear that experience. I'd like to say it's shocking, but unfortunately we know that this is happening to our young people across the country. In terms of what we're going to do next, we're going to open this out now to a panel. So on our panel, we will have Sarah, Annabel and Carole, who you've already heard from. But if I can ask everybody on the panel to turn your cameras on. I'd also like to introduce Goska. And Goska is a clinical social worker with the CAMHS Crisis Assessment and Treatment Team and has worked there since 2021 when they qualified. So I'm going to just pose the first question, who is from Jade. And this question is, following an AMP assessment for a young person, what determines where they are referred to? Is it similar to adults where admission under a Section 2 at an admission ward is a common next step? So who'd like to respond to that question? I think actually, Sarah, sorry as well, if you're able to just stop sharing your screen, that'd be great, thanks.
Okay, thank you. I mean, I'm happy to respond to that. I suspect it's probably different in different areas. Generally speaking, following admission to the ward, there would be a referral to CAMHS who would continue to support in the community. The Mental Health Act Code of Practice very clearly says that if a child has been admitted to the ward under Section 2, that they are to be considered as a child in need by the local authority. And I can see there's a number of questions asking about that connection between the local authority and the trust. And I have to say that practice, I don't think, is embedded nationally at the moment as to how those provisions fit together. And Annabel may be able to speak, and Carole perhaps a little bit more about their area. My experience up in the Midlands is that we've still got a long way to go. Our children's front door will accept referrals, but then really triage them to see if there's a specific need to be involved. And the health and the social care organisations, as you can imagine, are working with completely different thresholds and gateways and what they're able to offer. So there is a pathway following admission to hospital, but I suspect the national picture is it's very much based on the local services that are available, and really speaks to what Annabel was talking about earlier about the need for social workers to be embedded within both health services and children's services as they are already, because I don't know that those connections are necessarily there at the moment. And I think often the emphasis goes to who is caring for that child post-admission. So if it is that it's the local authority that has responsibility for their care, there's a network of support there. And if it's the families, then obviously it's connection with the families. And I'm not sure that services with that joined up, although in different parts of the country, there may be more effective pathways. So I don't want to throw anybody under the bus. It's just my experience in our area. So I'm happy to open that to Carole and Annabel and Goska to see if it's different in their parts of the country.
I just wanted to add, if it's okay, asking about section 2 for, I think you mean assessment ward. In our area for adults, we have separate wards for assessment and separate and longer term wards. But as there is a national shortage of CAMHS units across the country, we don't have the luxury, certainly that I'm aware of separate assessment. And so generally there's normally 1 or 2, if you're lucky, in your county, where whether you're on a 2 or a 3, that wouldn't necessarily be relevant.
That's really helpful. Thanks, Sarah. Thanks, Carole. The next question is actually for Annabel, and it's from Luke. Do you have any thoughts, awareness on models like I Thrive models in CAMHS and whether they might have positive impact in terms of social work and social workers in CAMHS?
Yeah, thanks, Luke. Good question. Yeah, so the way that CAMHS services are delivered, we used to talk about a tiered model from tier 1 to tier 4, with the universal services being at the bottom of the triangle and working up to tier 4, which would be your inpatient units. And we're now in the process of really trying to get rid of that old way of thinking, because it creates barriers between different levels of services. And we're talking about the I Thrive model, which was developed by the Anna Freud Centre. This very much has the child in the centre as thriving, and then thinking about what might meet their needs around the edges, with things like from giving advice and signposting to getting some help, to getting more help, and then risk support. And I think in terms of social work, and definitely in my trust, we're talking a lot about that risk support part being a key place where social work can sit, thinking about what's delivered in that section being around risk management, safety planning, network liaison, care coordination, and all of those kind of parts. A lot of the young people, well, a high percentage of young people that are coming through our services at the moment are arriving, as I've said, with a great deal of complexity and acuity, and are not at the point where they are therapy ready. Nor necessarily is therapy indicated as being helpful. So this is a key part where social workers are really coming into the fore, which is not to say that they can't also be offering therapy, because we certainly in my trust have a number of social workers who have additional therapeutic training, but it does create a specific role where social work can sit really nicely, actually. Thanks.
That's great. Thanks, Annabel. The next question, if nobody else from panel wants to come in on that point. The next question then is for Sarah, and again, this question has come in from Luke. So we've got, what do you think of the recent writing and thinking about section 13.1 and pre-interview meetings specific to young people? Do you think this might make a difference or be a useful path in practice going forward?
Yeah, absolutely. I think it's a really good question, and I know Carole touched on it when she was talking about the findings from speaking with children and young people directly, and I'm all over it. I have to say, I think we should be really making the time to make that pre-assessment interview available. The difficulty is I have to say, my experience is often these assessments are completed under a degree of pressure, both time pressure and pressure in terms of understanding the circumstances that this child or young person has come to us, because generally speaking, for whatever the circumstances, it is a crisis. They are at crisis point. That child is at crisis point, but often so are their families, and so are other professionals that are involved. And that can be so influential on the outcome. And if we want to consider using the least restrictive option, then we've got to allow ourselves the time to invest in that assessment. And I don't think AMPs at the moment have that time. And if there was specific guidance, as you're referring to, about how we engage and conduct pre-assessment interviews, I think it could have potentially a really positive outcome on the outcomes of the assessments. I do question how often decisions are made under that degree of heightened anxiety and pressure that ultimately you know, given a bit of time and space, might have been different. And coming from an emergency duty service perspective, although this is very controversial, is that often considering the right time to do the assessments can have a big impact on outcome. So, for example, wherever possible, we try not to assess children and young people after a certain point at night, because we know that nobody effectively is functioning at their best, including out of our services being available to that child or young person in the early hours of the morning. So we've really got to sometimes push back against some of the policies and procedures that are in place around timescales and assessment frameworks and those kind of things to try and achieve the best outcome. And I'm wondering whether the framework that you're referring to might give us the scope to do that. So I'm all in favour, in a nutshell.
That's great. Thanks, Sarah. Hopefully, Luke, that's answered some of your questions. I can see you've popped it. Thank you in the chat. But just going to June's point now. So June's mentioned around that interface between Children in Need, Mental Health Act, and the Children's Act. I know we've already touched on it, but I don't know, June, did you have any? Do you feel that addressed your point, or did you want to come in to say anything else on that? And did any of the other panel members want to say anything?
No, just to say, it is a BASWA issue that we make sure that Children and Families group are in touch with the mental health group. But it was good to hear from Carole that child and family social workers are doing the AMPS training, and I wonder if, from the BASWA point of view, we can encourage that more. No, it's complex, but I'm aware, for instance, that adopted children really often end up needing mental health services, and that's a particularly complex situation. So there are so many points of contact in the knowledge base as well as the practice base.
That's great. Thanks, June. Anybody want to come back from panel on that, or?
I was just going to say to that, Denise, I think this is another, these are conversations that are happening a lot of the time, and it's becoming more about we all need to be involved rather than it's one or the other, and it's about understanding each other's language. And that's where, again, social workers are proving invaluable, because people who are working in the NHS can straddle both and help interpret the different legislation and the different language and the different thresholds. So certainly in our area, we're doing a lot of network meetings and trying to pull people together using things like joint risk assessments, actually forming them together, and everybody being around the table and part of that. So it's us or them, it's all of us.
Yeah, and I'd like to follow Annabel's train of thought on that, really, if you don't mind me jumping on the back of what you've said, Annabel, which is that often my experience says that when it gets to crisis point, that it can lead to a fairly hostile environment across services, which is really unhelpful. And I think social workers are absolutely pivotal in breaking down some of those barriers between where those hostile environments can build. And I think BASWA does have a role in supporting this extremely vulnerable, marginalised group, which is effectively looked after children, both those that have gone down adoption pathways or fostering, or they're in residential care. I don't know that we're getting to the heart of the matter, that a lot of their trauma is due to the intervention sometimes of services and decisions that have been made. And I don't know that we're getting to the heart of that, because there's such, sadly, in the past, there's been very defensive practice, which often has been rooted in good reason as to why that practice has happened. But we are now looking at older children that have experienced that level of intervention and hasn't always worked out in a positive way for them for lots of reasons. I'm not looking for blame. What I'm saying is we need to break down the barriers to work collaboratively, I think. So yeah, that's just why I wanted to follow up from that.
That's great. Thanks, Sarah. And certainly in terms of the BASWA interface, conveniently enough, I support the mental health group, the social work and health group, and the children and families group. So I can act as a bit of a conduit between those groups in terms of where we're seeing some commonalities and where perhaps we may be able to invest some joint energies in trying to move some of these issues forward. So hopefully that will be helpful. I'm going to open it out more generally. Obviously, I think we've covered all of the questions in the chat. There's been some comments and some reflections in there in terms of the language used, and reflection, interestingly, in terms of what we refer to, whether it's a social care provision, whether it's an NHS provision, we're calling them mental health units, or we're calling them residential homes. I think that is actually an interesting point for us to consider. But if anybody has a point they want to raise, just before I wind up, if anybody wants to put their hands up, or if any of the panel members want to add anything that's not previously been considered or discussed.
I wondered if Goska might say, because someone's put a
Yeah.
comment in about there not being enough people training, and obviously she's about to start the training.
Absolutely. Goska, would you like to come in on that point?
Yeah, I'm just mindful of the time. Yeah, and I think it's really important. So within our trust, within HPFT, we are really encouraged to think about that developmental pathway and think about AMP training. So, but I guess from the conversations I had with people attending pre-AMP training, that's not necessarily the case in every trust. So I guess having that support and understanding from the team's managers and from leadership is really needed across the country. Because obviously the AMP training, the role is extremely challenging and it's extremely demanding, and you take upon yourself responsibility that gives you also a power to make some real change in young people's lives. But I think there is a need and the scope for more awareness of the role and more promotion of the role within children practitioners.
And what a perfect summary, really, or end to today's session, really, because if there was a call out in terms of understanding the role of CAMHS, social workers understanding the role of AMP, in particularly in relation to assessing children and young people, I think today's really underlined that and certainly articulated the value of the role, but also the need to kind of push forward in terms of other areas of the sector understanding that, and also our ability to affect change. I think that's been key. So I've just, before I do final thank yous, I've just popped a message into the chat for everybody. I was asked to share that today. It was a release from the Education Policy Institute. It's their response to the latest data on the delivery of Transforming Children and Young People's Mental Health Implementation Programme. So we were asked to share that with you. In terms, and helpfully, thank you, Beth has posted some links to some other events, recordings that you might find helpful if you found today's interesting. Could I just ask, Beth's going to post a little, this is the bit that everybody dreads when they attend anything like this, but Beth's going to post a link to our feedback form. If possible, could you just take 2 minutes? It's really brief. It just helps us in planning future sessions. And so that leaves me to basically say a huge thank you to Sarah, Annabel, Carole and Goska for today's session. It's been really informative. I think some of the information we've heard today has just really resonated and has had quite a significant impact, and again particularly the audio, so our thanks to that young person for sharing their experiences. In terms of going forward, the BASWA has got a social work and health group of which Annabel is a member, and we do reflect on some of the work around CAMHS as well as wider work within health, social workers in health, but we also have a mental health group. I'm going to pop my details into the chat, and if anybody is interested in either of those groups, or as June mentioned there, the Children and Families group, please feel free to get in touch. We will send out the slides, the presentations after today's event for everybody who registered. So a huge thank you to everybody who took time out of their day to attend today. We really do appreciate it. We understand that day-to-day practice is busy, and so actually taking this time to reflect and to invest in understanding some of these areas, we really do thank you for that. So take care, everybody, and yeah, have a good day.